Hello, good evening, everyone. Welcome to tonight's family webinar series. My name is Elaine Donnelly, and I'm really delighted to have you all here. I can see you trickling in for the sixth webinar in our family webinar series. Tonight, we're going to be joined by Sean Lonergan, who's a member of our bipolar program team and a CBT therapist. And Sean's going to be talking to us a bit about bipolar disorder and understanding that from a family perspective. As with the other webinar format, we hope to have some time for Q&A towards the end. So please feel free to pop any questions in the Q&A box and hopefully we'll get to them at the end. As with other lectures, the webinar will be recorded. And we're conscious that sometimes difficult emotions can come up and sometimes you might find some of the information challenging. So feel free to take a break at any stage or do whatever you need to do to feel safe in the knowledge that you can come back to it at a later stage as the webinar will be recorded and should be available on the website in the coming days. So without further ado, I'll invite Sean to join us and we can kick off on tonight's talk.
Hello, good evening. Thanks very much, Elaine. I really appreciate that introduction. It's nice to be with you all. I'm just going to bring up the slide deck for this evening. So my name is Sean Lonergan, and I'm a cognitive behavior therapist working with the bipolar education program in St. Patrick's University Hospital here. And in this evening's webinar, I hope to provide you with a greater understanding of bipolar affective disorder, sometimes known as bipolar or bipolar disorder, and how you can support and promote the recovery of your family and friend living with bipolar alongside caring for yourself. The learning aims of today's webinar are to clarify what bipolar affective disorder is, its types, effective treatment approaches, how you can helpfully support your friend and family member at different stages of recovery, and how you can best take care of yourself when supporting your family member or friend with bipolar. So the main rationale for this is that clinical evidence suggests that if a family and friends, those who support a person with bipolar, get educated in terms of they learn more about it and how its treatment works and how they can support a person, this can give significant benefits in decreasing the risk of relapse and hospitalizations in individuals with bipolar, as well as assisting in reducing the stress of caregivers. So one of the things that we're very hopeful when it comes to bipolar is that it can manifest in many different ways and it can impact daily life in different ways. And across time, that often can change. So both for the person with bipolar and those who care for them in terms of support them. So caregiving experiences can also change over time. So for some people with bipolar, for months and years, they may not have a significant episode of mood disturbance. Because everybody's illness is different though, for some people, they can have significant rapid cycling. So that's where there's significant mood disturbance up to 4 times a year. So it can be something that can be more significant or less significant, more regular or less regular, depending on each person's experience. So with bipolar affective disorder, it not only affects the life of the person with the illness, but also their close family, partners, and friends. And significant people in a person's life are often a source of support with the illness. However, family, partners, and friends may be faced with a loved one's bipolar illness without much information on ways to deal with it and support in managing its impact on their life. So it's important to know how to look after yourself as a supporter and caregiver as well. So a big portion of today's webinar is really about how you, as someone who cares about a family or friend or other person that you're in contact with bipolar, how you look after yourself in trying to support them. So finding what works for you to deal with your situation can be very much a trial and error process. And the idea is to learn as you go. So when you think about bipolar, probably a good place to start is, what is it? So bipolar is understood as a cyclical mood disorder, which occurs in cycles or episodes of mood disturbance. And it's a potentially lifelong and disabling condition. So bipolar disorder refers to a spectrum of disorders that involve unusual changes in mood, activity, and energy. These changes in mood or behavior are different than the typical highs and lows that adults generally experience. In bipolar disorder, the highs are called manic episodes or cycles, or in less severe cases, hypomanic episodes. And the lows are episodes or cycles of depressed mood. So what you'll notice in some of the slides I have, I've got certain links built in as well. So these are going to be in the references that will be posted alongside the video on the website, and I'll briefly show you them on the video as well a little bit later towards the end, which you can stop and have a look at in your own time anytime you want. Okay. So what causes bipolar disorder is something that quite a bit is known, but it's not something that's absolutely certain. So researchers and healthcare professionals understand that some factors contribute to bipolar mood disturbance, but do not completely understand what causes it. What is understood is that both nature and nurture can contribute. So what that means is that there's a certain amount of genetic, physical, environmental, and social factors. What is a key, but not necessary factor is if a person experiences trauma, stress, and adversity in their life, especially early life, it can leave them more vulnerable and more likely to develop mental health condition generally, but definitely bipolar. If there's a first degree relative who has bipolar, there's significantly higher rates of bipolar or chance of getting bipolar. Twin and adoption studies also indicate a genetic vulnerability factor. However, people who have no relation who has bipolar can still get bipolar, and those with relations with bipolar don't get bipolar quite often as well. So it's not necessarily deterministic, but it can increase the probability. And these are things that we usually think is a complex mix of different factors working together that can leave a person more likely to develop the condition and trigger episodes. In terms of diagnosing bipolar disorder, it's dependent on the specific criteria being met according to diagnostic guidelines. So a psychiatrist who's going to be assessing and potentially diagnosing someone bipolar, they can use two different manuals or guidelines. So one is called the ICD, so the International Classification of Diseases, and one's called the DSM, Diagnostic Statistic Manual. So the ICD requires at least 2 discrete mood episodes, at least one of which must be hypomania or mania. And the DSM-5 requires at least a single episode of mania without any episode of depression, or a single episode of hypomania with one major depressive episode. The duration of mood disturbance minimum in terms of time for diagnosis, mania requires an abnormally elevated mood irritability for at least 7 consecutive days or more. Hypomania requires an abnormally elevated mood irritability for at least 4 consecutive days or more. So it's a reduced amount of time. And episodes of depressed mood need to occur for at least 2 weeks for a diagnosis of depression or bipolar depression. So what we might think about now is bipolar disorder involves more than the ordinary mood changes people experience in response to the ups and downs of life. So sometimes what can happen is if a person is diagnosed with bipolar, people around them and they themselves, especially initially, can be hypersensitive to any changes in mood or emotional expression. So if someone's having a particularly good day or having a bit of a crappy day, could cause quite a lot of anxiety or misinterpretation as that's a bipolar mood disturbance. It could grow into that, but there are a number of things that differentiate healthy fluctuations in good day, bad day, okay day to something that's going into more hypomania or depressive states. So this involves mood episodes where the person's thinking, feeling, and behavior changes significantly, noticeably, for a considerable duration of time, and affects their daily functioning. These are the things that are very important to be able to distinguish healthy, natural mood shifts from more bipolar concerning significant mood changes. So sometimes the person will have no symptoms, sometimes they'll only have a few symptoms, and sometimes they might have an actual episode of mood disturbance. And I suppose for every person, they're trying to figure out, what does this mean in the moment when things are happening? And in the moment is not the best way to assess it. It's really over time. So knowing your loved one's typical personality and behavior can help you to identify when the person you care for is ill rather than having just a blue day, or particularly a good day, within the range of healthy mood fluctuations. So here, I'm just trying to illustrate the bipolar mood spectrum. So bipolar affective disorder is not just one diagnosis, really. It's broken up into a spectrum or a scale of a number of different bipolar types. And this ranges from marked and very severe mood disturbance into more mild or moderate mood variations that become more difficult as you get closer to the healthy mood states to differentiate with each other. So on the top end of high mood, you've got bipolar 1, which may be with or without psychosis symptoms. And on the very bottom end of the scale, you've got very severe depression, which may or may not have psychosis. A certain number of people with bipolar can have psychotic symptoms. Most don't, a good number do. But it's not something that definitely has to occur if you have bipolar. From the top end down, then in terms of reduced severity, you have bipolar 2, then you have cyclothymia, rapid cycling, mixed states or dysphoric mania. And then on the depressive end, you've got from mild depression, moderate depression, down to severe depression, again, with mild or moderate depression being just that slightly less severe examples of it. So what I'm going to do now is just try and illustrate what some of these types are. And if you want in the Q&A to go into more detail about the others, I'm happy to do that as well. So when we look at the classic form of the illness, what used to be called manic depression, and if the person on the street was asked, what do you think this is, they'd normally be talking about bipolar 1. And this is what involves recurrent episodes of mania and depression. So this is full-blown high mood with potentially very severe low mood. So a person affected by bipolar 1 has had at least one manic episode in his or her life. A manic episode is a period of abnormally elevated mood accompanied by abnormal for them behavior that disrupts their life. The duration of a bipolar 1 mood episode can vary. Again, the minimum amount that mood episode would need to last for it to be counted is 7 days. In terms of bipolar 2, this is where you have the milder form of the high mood, so mild to moderate high. Okay, still much higher than a good day, but not as high as a full-on mania, with then potential for still a very severe depressive episode. So you have more a moderate high with still severe lows. With bipolar 1, you have a severe high and severe lows, right? That's the spectrum you're working in. Then with cyclothymia, what you have here is more the hypomania, which is a mild to moderate high, but also mild to moderate lows. So there's not absolutely severe depressive episodes. So it's more than mild to moderate on both sides, which makes that a little bit different. And really that's diagnosed where you've had this mild to moderate highs and lows for at least 2 years in duration. So this is something that's been noticed over time. You're not getting quite the extremes of the disorder, but you're having significant mood disturbance beyond the general good days and bad days for longer that is functionally impairing. With regard to just the two others that were mentioned, when it talks about mixed state or dysphoric, if we go back a slide here, dysphoric mania, that's referring to a combination of depression and mania symptoms or hypomania symptoms. So that combination together means you have some symptoms of depression and mania at the same time. And rapid cycling, as I mentioned a bit earlier, is where you're having at least 4 episodes within a year. So it's a lot of cycles happening very quickly. So the key difference of being healthy with good and blue days is the severity of the symptoms, the duration of the symptoms, and the degree of functional impairment, resulting in difficulty being able to complete tasks and activities. So we're just looking at the scale there. So here's balanced mood in the middle, this is me being okay. And it's perfectly healthy to have a good day here and there, a bit of a blue day here and there, or even afternoon or whatever it might be. But it's distinguishable from hypomania. So this is going on for at least 4 days, right? This is when I'm in a better than a good day for longer than that, but I'm not necessarily way up here. And in the same way, I'm having a bit of a blue day, but it's not going on for days, or the number of symptoms is more limited than what would be called mild depression and beyond. So when we think about the symptoms of mania, it can include a good number of symptoms, but just to kind of illustrate them here, increased energy, activity, and restlessness is extremely common. Having excessively high, overly good, euphoric mood, feeling pretty fantastic. Extreme irritability at times, often maybe being very frustrated, things aren't moving as quickly as they want them to. Racing thoughts, talking very fast, jumping from one idea to another. What others would see as poor judgment, but they would see as pretty insightful, sharp thinking and judgment. Unrealistic beliefs in one's abilities and powers, often feeling particularly powerful and capable beyond what you typically might think. Little sleep is needed or desired, not feeling tired at all, feeling very energetic, distractible, difficulty concentrating, sometimes impulsive spending sprees, a lasting period of behavior that's different from usual. I know that's a bit of a broad description, but that's usually something to be looking out for. Something's changed, a lot of things possibly. Increased sexual drive and libido, abusive drugs, cocaine, alcohol, stimulants, sleeping medications for some, provocative, intrusive, or aggressive behavior with poor social cues, talking over, speaking, and being close to people when you're interacting. Denial that anything is wrong. So others might be concerned, but the person with mania would usually not be. So further symptoms can include what are called flight of ideas. So the pace of the person's speech may pick up, and they may speak rapidly with a tendency towards changing the subject frequently. The new subject may be related to the preceding subject, but it might not, and the connection might be very weak. So they're often jumping around from one topic to another. Risk-taking or seeking extra stimulation, and interaction is characterized by disinhibition or insensitivity. Enhanced sensory experiences. So everything might seem more vivid, more sharp, more clear. But bouts of creativity, so kind of feel very inspired. One of the characteristics of mania is that full insight into what's happening is often quite lost. The individual is unaware that their behavior is abnormal or problematic and does not consider him or herself to be in need of treatment. Clinical interventions may be seen as attempts to undermine the person's esteem and power and could provoke or worsen irritability, even in those who are predominantly euphoric. Although mania and hypermania are the defining characteristics of bipolar disorder, throughout the course of the illness, depressive symptoms are more common than manic symptoms. And depression symptoms are wide-ranging and can have an impact on the person themselves, their work, and relationships with family and friends. So you're kind of all in it together if you're living with someone who's very depressed. So physical symptoms within depression can manifest, such as sleep disturbance and gastrointestinal upset. And these are often the first indicator or reason for a person presenting to GP seeking help, especially in people who may find it more difficult to identify mood problems. So the GP is often the first person that a person might start talking with, saying, I think something's wrong. But they wouldn't necessarily know that it's depression, but they might be actually seeking help with what are symptoms of depression, but may seem more physical. Depression presents with an array of associated symptoms, and some of the effects can be on mood and emotion. So you'd expect pervasive low mood, loss of enjoyment, social withdrawal, anxiety, irritability, feelings of guilt and worthlessness. So guilt is where you think you've done something wrong, loss of interest and tearfulness. Also, when we look at thought and cognition, so how you think, there's often poor concentration, poor memory, impairment in the ability to concentrate, sometimes obsessive rumination on perceived things that have gone wrong in the past that they wish they could change, that they might feel guilty or responsible for having done something wrong or not having prevented something wrong happening. So a lot of regret, shame, and guilt. Hopelessness and helplessness are very common emotions. And suicidal thoughts for some people. In terms of the body, physical movement tends to be reduced. So a person has lower energy. They can be more nervy and fidgety. So there can be an agitation, an agitated depression for some people. Sometimes they're also anxious, which can be part of that as well. But quite often there's a slowing down and numbing down of the body and the mind. So the person's thinking and moving is slowed. So the body can be heavy, achy, somewhat unresponsive. You're moving slower, you're not moving as much, more monosyllabic, not very responsive, maybe more vacant. Often that combines with rumination. And to a degree, self-neglect is quite common. So you're not looking after your body, you're not eating, or you're overeating and undereating. You're not necessarily sleeping well, or you're oversleeping. There can be different combinations of things that can be happening there. In terms of psychosis, so this will apply to some, but certainly not all. So sometimes severe episodes of bipolar mania or depression can include symptoms of psychosis. Common psychotic symptoms include hallucinations, where you're hearing, seeing, or otherwise sensing the presence of things not actually there, and delusions, so false, strongly held beliefs not influenced by logical reasoning or evidence to the contrary. These can be shaped by the person's mood. So in terms of during mania, delusions of grandeur, where you're feeling and believing that you're extra special, so you have particular status and power, such as you're the president or someone fantastic in some way or other, will be common. In terms of during depression, there can be delusions more of guilt or worthlessness. So I've done something terribly wrong, or I'm, I have no value or status in some way or other. Now, one of the natural things that first things I guess they want to find out if they know someone who they care about who's been diagnosed with bipolar is, can this be cured? And I suppose the answer is not really, but there's no clear answer. So there's definitely no one cure. So some people will have a lifelong remission and never experience another episode of mania or depression again. This is rare, but it is possible for some. So you can't absolutely predict what will happen going forward after you've had a diagnosis. However, you can say in the likelihood and probability, usually, bipolar mood disturbance is recurring, and it's better to be prepared for that being a strong likelihood. So there typically will be periods when the individual remains well for a period, only to find symptoms reappear later. Much can be done to reduce the severity or duration of an episode, or even the number of episodes experienced. And the best treatment is usually a combination of medication, psychotherapy, and self-management, alongside support from loved ones. Although typically an ongoing and recurrent disorder treatments that involve medications and other elements of an individualized treatment program can help your loved one to be more resilient, manage symptoms, improve daily functioning, and help them lead a full and meaningful life. An individualized treatment program best includes positive family and peer support. And factors that can influence treatment outcome for the better or for the worse can include their medication adherence. So poor medication adherence tends to have poor outcomes. Suicidality, if a person is actively suicidal, then that can jeopardize a person's recovery. Presence of comorbid issues such as a personality disorder can just make, I suppose, the challenges of recovery more difficult. The quality of family and social support, if it's poor, the outcome is worse. If it's positive and strong, the outcome is better. Substance use would interfere with a person's recovery significantly. Severity of prior mood episodes. So bipolar 1 is the more severe episodes you have, the more that can leave you vulnerable to even more often occurring. The earlier the treatment onset, the better it protects a person from future episodes and maintains their recovery and quality of life. The age of onset, it can be a factor, but it's not a definite thing. But the earlier onset, the more severe it can be over time. Of those compliant with medication, half can relapse within a year. Again, this is based on statistics. It's not saying this is definitely what will happen for your friend or loved one. 3/4 relapse over several years, and there can be a continued role impairment between episodes for some, with poor medication adherence in particular. In terms of the treatments, bipolar disorder can be managed with a combination of medications, psychological therapy, family, and peer support. Now, not everyone will have all of those. Recommended combination is of medication and psychosocial treatments, and advocate a collaborative approach to the management of bipolar. That's working together alongside self-management. So that would be the typical care package that a person would get. Additional supports that can be very beneficial include supporting engagement in education, employment, if a person needs it, supported housing, vocation and career development. It's important for every person to feel valued and worthwhile and useful in their own way, and have a good outlet for activities and interests and activities of meaning in particular. So it's also important to encourage good self-care, such as a healthy diet, exercise, sleep, and abstinence from illicit drugs. And understanding how treatment works will help you play an active role in your loved one's recovery. Just to describe what I mean by self-management over here. So self-management is built on the principle that if you are able to recognize the early triggers and early warning signs of an impending episode and implement appropriate coping mechanisms, then greater control can be achieved over mood shifts and episodes. So hopefully you can intervene to prevent it, if not to reduce how severe and how long it lasts for, and allow yourself to recover sooner. So self-management programs aim to help the person living with bipolar to take an active part in their own recovery, so they're not controlled by their illness any more than they have to be anyway. So who's involved in offering treatment? For the majority of people living with bipolar, their GP will be their primary treating clinician. They may well not need any other long-term support, as long as they're doing reasonably well. However, many different treatment providers can be involved as needed. So the treating team can include the GP, psychiatrist, pharmacist, psychiatric nurse, social worker, occupational therapist. If they're working, they may have an occupational health worker who is helping them reintegrate back into work or work with them on maintaining their work. Psychologist, individual, couple, and or family psychotherapist, housing support, etc., amongst others that could be part of that. So there are many people that can be part of what's called collaborative care treatment. So it's a way for individuals and their family or friends to work together with their clinician to get the best results from treatment. So one of the things that I suppose they're trying to promote is what's called treatment concordance. So treatment concordance refers to the extent to which the individual, their clinician, and their support system, so family and friends who are involved, are in agreement about the care plan. So it's about how much you all agree on what's the best thing to do and how to support the person to be well. So elements of collaborative care include becoming knowledgeable about bipolar disorder and its treatment, which they're doing today, developing a system of supportive individuals to participate in a care plan. So who's going to be involved, if anyone, and learning how to communicate efficiently with clinicians, therapists, and other members of the support team as needed, and as much as you're allowed to, which we'll come on to in a little bit. One of the things that is a very important part of bipolar treatment is medication. So medicines aim to prevent and treat episodes of mania, hypomania, and depression. The intention is to improve symptoms and stabilize mood and other symptoms, which might be, I suppose, comorbid. So there are other difficulties alongside bipolar, or they're part of the symptoms of bipolar, which could include anxiety and paranoia. To optimize drug dosage, so what's the correct dose to get the most therapeutic benefit, what works for them, to minimize side effects. It can take months to start working, so it's really important to persevere. And it is a trial and error thing. Everybody's body processes medications differently. To optimize adherence, so greater risk of relapse if the treatment is stopped, especially suddenly, or the person is taking their medication not as prescribed, so very inconsistently, or with higher doses than they're supposed to, or lower doses than they're supposed to. So other medications are often added when necessary for shorter periods to treat episodes of mania or depression that break through despite the use of a mood stabilizer. So there are different medications interacting and working together on different aspects of the bipolar symptoms. These medications alter the chemical messengers active in areas of the brain that regulate mood, behavior, and thinking. And the brain communicates by neurotransmitters, which are sending electronic messages. And medication works by trying to change the amount of these neurotransmitters in the brain and regulating the effect of them on a person's mood. When it comes to understanding medication treatment, there are a few things to consider. So medication most often works, but not immediately. So one of the things that's really important is to really check what your expectations are, and also the person with bipolar. So if a person is thinking, if it isn't working in 2 days, then it isn't going to work, or it doesn't work, then some kind of firm conclusion is made. That can be obviously problematic for continuing to take it without giving it enough time or chance to work. Medication usually works best in combination with other treatments. So often you'll have a better outcome as you combine different forms of treatment together, which can be different medications, but also psychotherapy, etc. There are many different antidepressants, mood stabilizers, and antipsychotic medications available. Finding the right medication in combination and dosage for each person can take time. And treatment is a partnership with the medical team. So a person can be started on medication, and then it's checking in with how is this going, any side effects experienced, any benefits, or what's happening as you go along to find out really what is helping, what isn't. Stopping early or too quickly is a common cause of relapse. So that's one thing that is often stressed, that please try and stick with it, reasonably speaking. And if you're making a change, try to do so in conversation with your prescriber. So if medication isn't working or stops working, options that include making sure you've been on it long enough. Are side effects affecting the benefits? Can they be addressed? To increase or reduce the dose, depending on what might be more helpful, switch medication, add in another medication, combine with psychological treatments or other treatments. So severely depressed and not responding, electroconvulsive therapy or ECT can be considered. So the real important thing is trying to set out realistic aims of success with any treatment, looking at the different options and choices and trying to make the best one, and to try and have patience with it. Most symptoms have started over a long period of time and not a few days. So it can be unfair to expect them all to immediately go away or to recover sooner. When it comes to psychological therapies, there are a number of options as well. So cognitive behavior therapy, which I'm trained in and practice, and other forms of therapy, such as interpersonal and social rhythm therapy, and family-focused treatment have shown some good evidence of being effective in managing the symptoms associated with bipolar disorder. And these psychological therapies may be used alone or in combination with medications. Therapy also offers help for your loved one to develop behaviors and daily routines that can protect them from experiencing severe and prolonged symptoms. I suppose in terms of how much detail I go into about this, so there are a number of psychological therapy treatments. They can help in lots of different ways. Some of the particularly important ways are to improve compliance with medication use, helping normalize the sleep pattern. So the sleep-wake cycle and hormones tied to sleep are very important. Reducing high expressed emotion, which I'm going to talk about shortly, and reducing the impact of stressful life events to reduce stress hormones affecting mood. Encouraging healthy exercise, diet, and self-care, improving the knowledge of and understanding of signs and symptoms of relapse and protective factors for maintaining healthy mood, and developing a relapse prevention and mood management plan. Again, I'm going to talk you through some of those as we go along. So CBT, short for cognitive behavioral therapy, this approach is really trying to enhance the compliance with recommended treatment. And the intention is to understand and learn from the impact of past episodes, encourage monitoring of mood, and develop specific strategies for dealing with mood-related thinking and behavioral difficulties. So I'm not going to go into as much detail as I could on that one, but I'm happy to provide more if you wish. So just to give you a general overview, so the cognitive behavioral approach to managing the cognitive and behavioral changes associated with mania, hypomania, and depression include recognizing social mood, thinking, and behavioral changes to allow for early intervention, evaluating and changing distorted or unhelpful thoughts and beliefs or ideas, such as suspiciousness, grandiosity, or worthlessness, organizing and scheduling of activities, ideas, or plans with the aim of limiting and containing overstimulating activities when high in mood, and behavioral activation in line with values when depressed. So that's activating the person to be able to get to do more or that's meaningful to them when they're more withdrawn and shut down when they're depressed. So we're finally on to probably the most important part for this particular webinar, really, and that's you, the peer and family support. So peer and family support are very important for people living with and recovering from bipolar disorder. Family members, friends, and caregivers with positive attitudes and peers who are recovering from similar disorders can be great assets to people recovering from bipolar. As a partner in your loved one's recovery team, you can help to identify problems early and provide important support and encouragement to help your loved one engage with recommended treatments, including medications. You can also help them stay focused on their recovery goals. Additionally, talking with other supporters who also have a loved one diagnosed with bipolar disorder can help you to learn more and know what to expect. You may benefit from having someone further along in the process with whom to discuss your own questions, thoughts, and feelings. You may choose not to do that, and that's fine, but I will be talking through where you could access support and interaction with other people who are family or friends of someone with bipolar. So how can you help? So it's trying to figure out, I guess, really, how can you help well and how can you not help in a way that's unhelpful? So the best mental health care comes from a partnership between professional treatment providers, if involved, which they may not be, if the person's quite stable and well, the person living with bipolar and their close supporters. As a supporter or caregiver, I'm going to use these two terms somewhat interchangeably. You might not think of yourself as a caregiver, but you might reasonably think I do try to support the person as best I can. Your informed care and support can make all the difference. So you can help by both you and your loved one learning about bipolar affective disorder, effective models of treatment and care, and how to support recovery. Encourage and support collaboration and treatment concordance. So again, that's what being agreed between the clinician, the person with bipolar, and you, if you're allowed to be involved in that treatment plan. Bipolar disorder can manifest in many different ways. We started off saying that. And also caregiving experiences differ. What's happening for one person can be quite different for another. So yeah, you can have one diagnosis, but a real range of different experiences. And that can also change over time. So finding what works for you to deal with your situation can be a trial and error process. And along the way, it is vital to acknowledge and give your loved one and yourself credit for what you're already doing to help manage the symptoms of bipolar disorder and promote recovery. Family and friends involvement can be very important in aiding recovery and helpful management of bipolar affective disorder. So when we think about supporting a person's recovery, there are three parts. So education, treatment, and support. And those three together really add up to improve chance of recovery and resilience. Resilience meaning less likelihood of further episodes occurring or disturbance or impairment in a person's functioning. So when they are well and maintaining their recovery, we want to look at different parts of the, I suppose, recovery process, okay? So they can be well, they can be becoming unwell, they could be in a crisis, and sometimes in a crisis, they may be hospitalized and then post-discharge. So we want to look at how maybe you can help them depending on which stage of recovery they may be in. And we do really think about this, that your loved one at times may need more or less support. They may need different types of support, and they may be more or less willing to accept and be able to accept that support. So these things can really be changeable. Trying to be patient with their emotional changes and swings in mood is really helpful. So when first diagnosed, or if your loved one is having an episode, it can be an especially turbulent and difficult time. Caregivers can experience a range of reactions when trying to come to terms with the person's illness and its consequences. For many, not necessarily all, there can be grief. And within that, there may be anger, blame, fear, denial, confusion. There can be a lot of different emotions happening. Often it can be a loss of what you thought your future was going to be, or uncertainty about what's going to happen next. And if you are grieving, try and allow yourself to grieve and acknowledge your emotions and natural reactions to the changes and losses that the illness has brought. Anger, sadness, anxiety, and depression are common emotional responses to getting this kind of diagnosis. And trying to be tolerant, keep calm, and offer a smile or a hug is a great way to reassure. It's really helpful to try to separate the illness from the person. So one of the things I've just tried to illustrate in this little table here is the spectrum of, I suppose, versions of that person that you care about may present to you. So high in mood, they could be very sociable, talkative, enthusiastic, energetic, assertive, confident, impulsive, high sex drive, extroverted, very, very full on. In low mood, they could be the exact opposite. Extremely withdrawn, quiet, unenthusiastic, apathetic, passive, shy, anxious, low sex drive, detached, tired. And then you might have them when they're healthy, which could be quite a different sort of person, somewhere in between those extremes, quite likely. And your relationship and experience of your loved one may vary very significantly, not just with those three, let's say, types of person that you have there, depending on where their mood is, but also their stage of recovery. So it can be a little hard to get your head around, how to relate with someone that can be very different with you at different times for perhaps quite prolonged periods of time. So you can be talking weeks and months in different mood states. So remember, bipolar disorder is a complex illness that typically needs ongoing management rather than something that can be fixed forever. It can be helpful to manage unrealistic expectation of yourself. So sometimes what that means is, are you expecting yourself to be Superwoman or Superman, able to do far more than might be reasonable of your loved one. So you might expect them to just get well again when really they're not able to do that. The therapist or doctor just fix them. There might be different expectations that can be there that may be realistic, but maybe unrealistic. So trying to find out what is realistic to expect is very, very helpful. People living with bipolar can and do live fulfilling lives, whether it's going to university, starting a new job, traveling around the world. This can be done if your loved one is feeling well. Making sure to look after yourself with bipolar and ask for reasonable adjustments in the workplace if you have bipolar can help if you are working. It is okay to disclose you have a disability, but you may not like to think of yourself that way or wish to disclose that, which is perfectly within your right to decide. But as long as episodes are fairly under control, and with this, everyone is different, it may or may not be, your loved one can still achieve. Small achievements are just as important, and just make sure it's achievable and realistic at the time. Bipolar disorder can challenge relationships, and sometimes it takes a bit of time, patience, and effort to maintain or rebuild them. Once the person is not ill, it may be possible to slowly regain some of the closeness that may be lost, but not inevitably, during an episode of illness. Some common challenges can be your loved one refuses to take medication or to take it inconsistently. It can be difficult to see your loved one relapse, perhaps repeatedly, following their choice to discontinue taking their medication or refuse to take medication overall. It can be difficult not to blame or be frustrated or angry if your loved one behaves and makes choices when unwell that cause embarrassment or conflict, such as sending inappropriate messages on social media or overspending causing debt, amongst others. So there can be quite a lot to be reckoned with that can affect a person's relationship and your ability and willingness to support them. And one of the things that we think about when it comes to family members and close friends of those with bipolar is called expressed emotion. So expressed emotion is the general level of criticism, disapproval, and hostility expressed. People recovering from bipolar affective disorder are considered more likely to relapse if their families, in particular, rate high in expressed emotion. So that would be high amounts of criticism, disapproval, and hostility. Low expressed emotion involves reserved criticism. So it can still be critical, but it's less often more constructive form. Limited hostility and contempt, and greater acceptance and caring concern for the individual. Friends and family members with high expressed emotion tend to be more hostile, blaming, and very critical. Examples are believing the person is choosing to be ill and not get better, is uncaring, especially when depressed, and not tolerant of the person living with bipolar affective disorder. They may feel like they are helping by having this attitude. So they not only criticize behaviors relating to the disorder, but also other behaviors that are unique to the personality of the person. They may not care for the person's independence or respect their judgments. So you might think, I need to take control when they're in chaos with their mood. But even when they're well, you may still adapt that more control-oriented style. So it could be, do what I'm telling you. You can't do that, do this instead. You might be perhaps more emotionally over-involved, too protective and too overbearing, which would come in within the realm of high expressed emotion. Those types of attitudes and behaviors tend to, unfortunately, undermine recovery rather than enable it. So family factors can really influence the course of recovery from bipolar. You may experience a range of intense emotions in response to the person and their illness. That's very likely. Some of these feelings may be part of the process of coming to terms with the illness. Others may be reactions to your own situation, so the consequences of that for your own life and well-being. Acknowledging these natural reactions and deciding how to deal with them can make it easier to cope. If you are feeling angry, try to find a constructive release for your anger, whatever that may be for you. So these examples I'm giving may not be your thing at all, but could be go for a walk, play sport, paint, write in a journal, talk things through with someone you trust, as general lifestyle things that can help you manage your own stress and well-being. If you're angry about something the person has done, it can be helpful to wait until you've calmed down to discuss the person's behavior with them. Try to delay discussing your angry feelings until the person is well and more able to deal with these issues. Perhaps do something you enjoy to distract yourself from feeling sad or rejected if they are withdrawn and irritable and depressed. Try and stay connected to others that you are close to, so you do have companionship and support. If you are sad about the way your relationship with the person has changed, try to rebuild the relationship, especially when they are well again. At times, you may feel like you want to withdraw from the person, and for some people, sometimes it may be to leave them. If this happens, try not to be critical of yourself. It may be a feeling that passes. You may be exhausted and need to take some time out for yourself. On the other hand, if you do decide over time that you cannot continue in your current situation and would like to leave or withdraw from your relationship with the person, or maybe your responsibilities for supporting them, it is helpful to first discuss what you're going through with the person involved. You may be able to find ways to resolve some of the difficulties together. Speaking to a counselor or relationship or family therapist may be able to help as well. So one of the things that we cover within our program of supporting people with bipolar is encouraging the person to identify a key supporter or spotter. So you can use either name here. And what this means is a formal three-way working relationship involving the patient, doctor, treating team, and supporter. Someone who knows the person very well can spot when the person is becoming unwell, and someone who the patient is comfortable with relinquishing some control when feeling unwell. A supporter could be a significant other, relative, friend, work colleague, GP, member of a support group. It is for the person living with bipolar to decide. And if when a supporter is agreed upon, it is important to discuss collectively what the supporter's responsibilities are and are not. If you become or are a key supporter of a loved one with bipolar, it's helpful to discuss and clarify with your loved one, how would you like me to approach you if I see changes in your mood? How would it be best for me to support you if I'm concerned you may be becoming unwell? How do we deal with potential conflict to preserve the relationship, especially if you disagree or become irritated if I raise a concern? And to develop a supporter contract and wellness plan. So decide what should be included in these plans and discuss this with the treating doctor or team. And we'll look at that in more detail in a moment. Sometimes there can be concerns that healthy behavior, irritation, frustration, or conflict is interpreted as symptoms of bipolar mood. So that's where a person, reasonably speaking, is annoyed with you about something that's happening. And they express that. And they get told that, oh, that's your bipolar. Or that's you in some way being ill. And that can be very frustrating for a person with bipolar to, in some ways, have their diagnosis be stigmatized or undermined or misinterpreted. At the same time, that might be the case. So it's a bit of a tentative tightrope, really, where on both parts, it's important to be thoughtful about perhaps what it is or it may not be, and try not to assume too much. And if there is conflict around that or it's upsetting, it is helpful to talk that through. So recovery can be supported through developing and putting into practice a mood management care plan. It helps if this is shared with key supporters to promote recovery. The goal is to balance risk and protective factors. So situations or factors that could make you at greater risk of having a mood episode and factors that protect against that happening. So we know that in terms of self-management, when the person is trying to look after themselves, Having a very healthy, good routine that's pretty consistent really helps, especially around sleep and diet. Building good coping strategies for managing stress, making appropriate use of formal and informal support, and tracking a person's mood are really helpful. So it does help to understand what early warning signs might be that you're becoming unwell, also to identify potential triggers for becoming unwell. So relationship breakdown, significant stressors, not sleeping, etc. There could be many different factors. And recognizing what changes for a person, so they can understand what might be early warning signs. So knowing how the person typically thinks, feels, and behaves when well. So you can contrast that with how they might be thinking, feeling, and behaving when they're starting to become unwell, and how they seem to maybe think, feel, and behave when they're quite or very unwell. So that you have a sense of comparison between healthy mood and degrees of becoming unwell. Then what's called a relapse prevention and management plan, where you develop an action plan if you're the person with bipolar for what can I do? So we really want the person to be able to take responsibility as far as they can within their own mood state at that time. So what can I do to try and protect myself, keep myself well? And also what can others do if there's some concerns happening or different events happening? So detecting and coping with early symptoms of relapse is really helpful and important. It may arrest the progression of symptoms into a full-blown episode. So if that can be achieved, that's really ideal. So it helps to review the mood management plan regularly through experience, learning, and progressively developing the plan over time. It can help to talk to them at a time when they're feeling really well and write down together a plan for when they are ill or have a manic episode. If you can agree their wishes in advance, it can help because you can action what you've agreed without feeling guilty. So when we were well, they said that this is okay for me to do. They might disagree when manic or depressed, but I know that when they're well, their healthy self is okay with this. So I've got permission. During a manic episode, your loved one may not want to do anything or some of what you've agreed. Okay, so as mood changes, so does the way a person thinks and behaves. So you still respect the other person's point of view, but you're also keeping in mind what you've all agreed together. Important things to cover can be which, if any, family and friends they don't mind you telling that they're ill, and which family, friends, work colleagues they don't want you to share this information with. So what information do you want shared with whom, in what way, if at all? If they want their phone taken off them, for instance, if there's been a history of, let's say, inappropriate posting or calling or messaging or things that were regretted in that regard, would they prefer some sort of limitation put on their likelihood of doing that again? If they want their spending restricted, so a cap on spending, like so say Revolut, where you have a very specific amount that you have in terms of the card, or take the bank card off when they're particularly unwell, or somehow protect them financially. How you agree to look after them at home if you are going to be part of that. How you help them assess when they're ready to go back into work. When you stop them drinking or drugging, well, you may not be able to do that, but intervene to try to do that. And if, when, to remove them from social situations, if there's a concern. To write down and sign if they're giving you permission to ask hospitals about their medication. Hospitals can be very strict on this, and we're going to talk about that in a moment. So in terms of support options, it's helpful to know different details for who's involved if they are in the person's care. So have their contact details. So it could be the GP, psychiatrist, psychologist, counselor, or therapist, other family members, key friends, key supporters, next of kin or legal guardian. In an emergency, the guardian or ambulance, so 999, 112. The HSE you could contact if you have some concerns or to talk through things between 8 a.m. and 8 p.m. Monday to Saturday. You might well have the numbers for, not necessarily for you, but for your loved one, in terms of if they are suicidal or need some support with those kind of concerns. The Samaritans, 116, 123, Peter House. And if they're involved with St. Pat's, you might be, if you were maybe looking for some support or advice around admission or different things, you could look at the support and information line, which is 01249-333. If the person is having addiction support, they might have a sponsor. So there might be lots of different other people that could be involved that you might want to contact or know how to contact if needed. So one of the things that we really want to emphasize is communication. So communication with treatment providers can be challenging because patient confidentiality is protected by health privacy laws. Caregivers sometimes do not feel as included, actually quite often, in their care discussions as they feel they should be or wish to be. This is typically not what treatment providers are seeking. So more often than not, most effective treatment is collaborative, where you're working together, communicating together as a team. However, sometimes the person may not want family or friends involved, and the treating team must not share protected health information with anyone else if the person, who's an adult, does not grant them the permission to do so, and they have the capacity to make that decision. You have to be thoughtful about this. So mental health treatment is sensitive and private. It is not unusual to feel vulnerable when experiencing depression, high mood, anxiety, or psychosis. At the same time, as a family and friend of someone who's experiencing bipolar or maybe admitted, you might be extremely concerned and want to know, understandably, and be involved. So it can be quite hurtful if a person does not allow you to be involved. Sometimes people with mental illness may not trust their family members or friends, especially if they've had trauma, adverse experiences, or if they're maybe suffering from paranoia at the time. It's also important to remember that not all families and friends are supportive or involved, and others may behave in ways that make the person's challenges even harder to overcome. So if the person in care is an adult with capacity to make sound judgment, the treating team must respect that. If the provider decides the person does not have capacity to make decisions, they're too unwell, information may be shared with family caregivers, but only if the provider feels it is in the person's best interest and on a need-to-know basis, and with very much respect for the rights of the individual. On the other side of that, you can always share information that you feel is relevant with your loved one's treating team. You don't need permission in order to do that. So you can give information to the person you care for, to their team, although they may be busy. And it is wise to contact them only as much as is necessary. And due to confidentiality procedures, so sometimes they may not be able to even acknowledge that the person is being treated there if they don't know of you or have been given permission to tell you about that person being treated. The care team may or may not acknowledge that information you share. They'll listen, but your message will still be considered. So they may not be able to tell you that that person is there or what they're going to pass on or not, but more often than not, it is passed on in that case. So as long as it's not detrimental to that person's mental health and well-being at that time. So to the extent possible, the best strategy is to work with your loved one and the mental health team to identify what information should be shared, by whom, and under what circumstances. And this is constantly reevaluated. So planning ahead helps you arrange practical steps to meet the care recipient's needs while conforming to professional ethics and legal standards. So in terms of practicing healthy communication on an everyday level, active listening is where you're really paying attention to what the other person has to say. Making a positive request for change can be helpful if the person is doing something that you would like them to do differently. Trying to calmly, as best you can, express your feelings about the person's behavior. Try to problem solve together. So not just tell them what the solution should be, but talk together about what it could be. Reaching a compromise together, if needed. Try and communicate about positive things, so it's not just all about problems. Can help to develop a crisis communication plan as well. So talk with the person you support about the value of caregiver support in treatment and the need to communicate with providers. Try to stay positive, listen with an open mind. It might be if they're going into hospital, you could ask them, how would you like me to stay in touch with you? Would you like me to visit you in person? Would it be by telephone, by email, by text? What would your preference be? Be open with your relative or friend. If you plan to communicate with the training team, explain what you intend to share and why in a gentle but straightforward way. Honesty tends to build trust. One of the things that we can suggest sometimes is that you try and keep a record of significant events that might be important in terms of medication or how a person might have been responding to different events in terms of protective factors or things that left them at risk, so triggers, any information that could be useful when you're talking with the training team. So supporting a loved one when they are well is very important. So we're not just talking about when there's a problem, but when things are going well. So it helps to educate yourself regarding bipolar affective disorder. It helps to consider this as a family matter. So it's not just the person with bipolar, but it's all of us in it together. Acknowledge that one family member's bipolar affects the entire family. Everyone in your immediate family could benefit from learning about bipolar disorder. Again, this is as far as the person with bipolar allows this or wants this. Its symptoms and early warning signs, how bipolar is treated, and what the side effects of bipolar medications may be. It helps to be a partner in treatment if you're willing to and you're allowed to. When allowed to meet with the treating team, try to be understanding, let your family member continually know that you care about them. Trying and take care of yourself. So part of that can be setting healthy boundaries and how much you do so you don't burn out. Consider how involved to be in helping the person with their illness and in what ways. Try to find social support, develop a crisis plan, and try to maintain hope. In most cases, bipolar disorder is treatable and can be stabilized. It can help to invest in maintaining a close, supportive relationship, but it is also important to maintain boundaries. So like any relationship, it's important to share enjoyable experiences that have nothing to do with illness. Encourage giving and taking in your relationship rather than just caregiving or a supporter and patient idea. Cared for person. Ask them to help out at times as far as they are able, providing they are not severely unwell. Relationships that involve even initial giving as well as taking can be less stressful and more rewarding for both people, and the power dynamic is more even. Keep in mind that although you can help, the person needs to find ways to deal with their own illness. Enjoy the person's efforts to make their own interests and identity. So that's where you might be letting go of the control and just allowing them to explore and be independent as far as is reasonably possible. Maintain contact with friends and family for you and for them. Do something that you enjoy. So it's an expression, water the flowers and not the weeds. So think about what you're nourishing, what you're focusing on, what you're giving your time to. Set limits with risky, dangerous, or inappropriate illness behavior you find unacceptable, and acknowledge you have your own needs. So you can use the time with the person as well to focus on things that are important to you. So you might have the ability to step back and really allow yourself to go, make sure that you're living your life as fully as possible too. And learning to say no to unreasonable demands, whether that be them asking you to do things in caregiving or other things that you feel are not appropriate. If your loved one has been hospitalized, you might want to consider your role in the planning for discharge and ensuring a successful transition home. Again, this is as much as you are allowed to be involved and be looking at being included in discussions and being educated around what the plan is. So we're looking at 3 parts. So educate yourself around next steps through the hospital stay and the discharge process. try to be as included as they're allowed to be, and to support the person as a full partner in the process, and to discuss. So what areas you're going to be involved in, or you might support them at home. What might this look like? So when you get home, what kind of day-to-day experience might you be focusing on? So you might be reviewing medications. You might be part of the checking in with what you're noticing around warning signs or problems going on, an objective sort of check-in for them. Explain test results or make up follow-up appointments if the person doesn't feel up to it. So many individuals experience challenges after being discharged from hospital. They may still have some symptoms that are active. They may not be fully recovered, but they're well on the way. And adjusting back from a high support base within the hospital with lots of activities and things to occupy them to being home and not quite sure what to do can be quite difficult. So challenges post-discharge can be avoided or minimized through proper planning. And the discharge process requires open communication. It helps to have knowledge of the healthcare system and information related to local supports and services. So you might be engaging with the GP or a community mental health team or other supports. Most importantly, supporters should be advocates for both themselves and the care recipient. Can help to offer structure. So around when you might eat together, if they're willing to, or you're okay with that. What the morning routine, so when you're getting out of bed, walking or exercising together at a particular time, taking medication at a particular time, a call to check-in if you're at work, just to sort of say hi, wind down for bed routine. All of these basic structures and routines can be very helpful in offering stability and helping that initial transition home and recovery overall. So some people might want a bit of support around their medication. It might be writing down, what's happening. Some people will want to give that control over. Some people won't want you involved at all. So it's about talking about, really what between you seems like the best way to go. And take some things with a pinch of salt. So sometimes your loved one can say and do things they don't mean when they are ill. Try to let it go. If they are ill, they probably won't remember, or they won't necessarily be responsible for what they did. And this can help separate the illness behavior from the person, the healthy person. So one of the things that we often encourage people who are diagnosed with bipolar to do is to have the opportunity to speak with other people who have a similar diagnosis. And thankfully, there are different options available in Ireland. So face-to-face support groups and online groups can both have a positive impact on recovery. They've been found to positively influence education and awareness of the illness, the interpersonal challenges, and effective treatments. The support group can offer a lot of things. So you might be able to meet with people who have walked in your shoes, what it might be like. Again, experience differs, but there's often points of relatability, who have unique insights into the illness that they can share and are willing to be with you in a time of crisis. You may not feel the need to explain yourself as much. You may feel more understood, be less in fear of judgment, and better supported. And all of that is helpful. And if a person is more isolated, especially so. So we are at the moment have a Living Well with Bipolar Disorder program. And here in St. Pat's, we have the Bipolar Education Program. We have a number of different group supports that we offer. And Recovery in Ireland, so recoveryireland.ie there, they also have different group supports available for the person with bipolar. Now, there are supports also for family and friends of someone bipolar, so I'll look at those in a moment. But when you think of yourself, you can have a similar strategy for supporting yourself as your loved one. So you might develop a good routine, in particular, a healthy, regular sleep-wake cycle, good coping strategies for stress, making sure you have good formal and informal supports, and make sure you're managing and monitoring your own mood, which can be affected by the different events that happen. So caring for the caregiver or supporter, so caring for yourself really, it's not being selfish, it's saying, me too, I need help too. So we have a little saying here, you can't pour from an empty cup. So you really need to take care of yourself. It can be kind of challenging experience being a key supporter of anybody in need. So Aware also have a specific relatives and friends programs of people with depression and bipolar, which is certainly worth looking at. Family carers in Ireland also have support for carers. If you're a young carer, you can also have specific young care groups for people your own age, which can be worth looking at. So there's a number of different supports that are worth exploring. And here are some blogs just for other people who are family and carers and friends of people with bipolar, just different hints and tips and supports that are worth a look at. So in terms of caring for yourself, it can be important to look at your physical health. So just your own physical activity, sleep, diet at a minimum. Perhaps your spiritual health, attending to your spiritual side can take many forms. So this could be religious and prayer, it could be meditation, yoga, it could be spending time in nature, personal writing, attending worship services of different forms. Emotional health, so having your own support system. Who's looking after you? How are you looking after yourself? So having someone to talk to whom you can trust can make it easier to cope, like a family, friend, counselor, other supporter. Consider maybe sometimes delegating and sharing caregiving responsibilities to others if you're feeling really tired or burnt out or it's just too much sometimes, and trying to be organized as best you can. Try to reduce your own stress or depression if you feel that way. You could do that in many ways, but to do something for yourself that you enjoy, find meaningful, and fosters closeness and intimacy with others can often be very helpful for building that resilience. In terms of reducing stress if a crisis occurs, so caregivers can often feel, not often, but can feel exhausted and overwhelmed when going through an illness-related crisis. It's quite difficult all around in that case. Stress can be reduced if you prepare in advance for times of crisis. Ways to reduce stress in an illness-related crisis can be to reassure yourself that the crisis will pass. If you are feeling very stressed during and after a crisis, perhaps talking to someone you trust or contact a helpline or support group. To schedule a bit of time to relax and unwind after the crisis, even if you are very busy. If the person is ill, irritable, and very critical of you, it can be hard to maintain perspective. And it can be especially hard if you're also irritable and critical of them. So there's quite a lot of conflict going back and forth. So finding ways to detach and set boundaries without being drawn into arguments can be helpful. It may help to detach from the situation a little by reminding yourself that the person is ill. Don't try to defend yourself by arguing logically with a person who's really unwell and maybe not thinking clearly. Try to address the specific comments or behavior. So if it's shouting that are unacceptable or concerning, without criticizing or blaming the person as an individual. So it might be, I understand you're upset, but I'm not going to tolerate being shouted at in that way. And perhaps it might be to walk away. Try not to be drawn into reacting to the other person's irritability or believing their criticism. Again, that's not easy to do. So if a person is ill and irritable, we were just looking at that really there. It's sometimes also helpful to think about taking a time out. So sometimes that hard work can be emotionally taxing and psychologically draining. When taking a short step back does not allow both of you to truly manage your heightened emotions, a timeout may be beneficial. So disengage from a highly charged situation. So kind of just get a bit of space from each other. What can help sometimes is if you have a retreat, a place to go, at times if you're overwhelmed, knowing where you can go to calm down, where it can offer a measure of peace and safety. A retreat is a space such as a room in your house, which is your area, a more comfortable place to be when you need to soothe, calm, and reduce stress. This space could be filled with books to read for leisure, workbooks, journals, plants, colored pens, or a pillow that says it will pass, or happy. It could be a place outside in nature that you find soothing or calming. It's really whatever you want it to be. But what's important is that you feel like you have a place that you can be safe and just be able to help de-escalate things if need be, and just look after yourself. It does help to be effectively problem solving. It does help to be able to manage boundaries. So if someone's really pushing you very forcefully, to be able to say no to demands that are unreasonable or unmanageable or dangerous. Keep in mind that although you can help, the person needs to find ways to deal with their own illness too. And it's very important that you look after your own financial health and well-being too. So try to protect your own finances if they may be vulnerable when a person is unwell, or just all around, if you're helping support somebody. So if this person you support is ill a lot of the time, again, the majority of people, this won't be the case, but sometimes that is. Some people have patterns of illness that are more severe and enduring. They may relapse more frequently, or their illness may be more resistant to treatment, and this can be very challenging. If that is the case, find out what resources are available to support you, them, and the family. It might help to make some lifestyle changes to cope with your loved one's persistent or recurring illness. It might mean rethinking the household budget, adjusting work hours, and maybe arranging to have more support with others. Ultimately, if you can change that situation, perhaps focusing on what you can control and the supports you can access. So, we really want you to look after yourself, and hopefully the person with bipolar as well. For the majority of people with bipolar, they can live great lives, be very content most of the time, be well most of the time, but have times of difficulty alongside close friends and family the same. So it's really looking after yourself is a big part of looking after them. So in conclusion, I hope you have gained a better understanding of bipolar affective disorder and its treatments, and how you can support your loved one with bipolar and yourself in supporting them. Building and maintaining long-term relationships takes real commitment. When a loved one is diagnosed with bipolar disorder, it can certainly add a layer of complexity to the rewarding connection you may have. It does not mean having a successful, meaningful, and stable relationship is out of reach. In fact, collaborating together, working together, can serve to deepen your dedication to each other. So I'm very happy to take any questions and explore some answers. Just to show you, there are some different references that I have from what I was talking through here today. These are hopefully going to be posted alongside the recording on our website. So you'll be able to have a look for those if you want information, or to look at links to other resources that I've touched on, and some that I haven't, but could be useful for you too, if you get the opportunity. So I'm happy to, if there is time and you're willing to do that, just maybe come back out of here and we'll go from there.
Thank you, Sean. And really valuable, comprehensive presentation. I'm conscious I'm getting a bit of feedback and I'm having trouble starting my video as well. So there's a couple of comments really, Sean, just thanking you for the presentation, and great to know more about the illness and its pathway, and also great to hear that the slides in the recording will be available. Just, I suppose there's a question from one participant who's wondering about whether somebody with bipolar 1 can be in a healthy relationship, and maybe, your own thoughts and your own perspective on that.
Can they have healthy relationships? Is that the question? Yeah, sure. Well, I work with people with bipolar every week, and most of them are in healthy relationships. They have challenges within them. Many people are married or in long-term relationships, or have certainly had very fulfilling relationships with friends, with partners, with family. Naturally, relationships for a person without bipolar can be challenging, but with bipolar can be just extra challenging at times. So it's another layer to be sort of worked with and on, but absolutely it's possible. Does it guarantee anybody that they will? Not necessarily. So it is definitely something that sometimes there might be some extra support and sort of things to address within relationships. I guess that's what I was trying to touch on within
yeah, of course.
webinar.
I think it's very important that that message of hope is there, and that lots of people, and that would be certainly my clinical experience, that lots of people are in healthy relationships, and that your illness diagnosis isn't determined, the kind of relationship that you have, and that absolutely education and support is essential to minimizing some of the maybe difficult aspects of supporting somebody with a mental ill health difficulty. I think that's probably all we have time for in terms of questions today. But as you said, Sean, the slides will be available, and there's a huge amount of resource there for participants if they want to review that in the coming days, and the recording will be available as well. But thank you all for your time, and thank you to Sean for joining us this evening for a really comprehensive presentation. I hope everyone has a nice evening.